The rationale for periodontal treatment, objectives. The main objective is to eliminate the pain, okay, and eliminate gingival inflammation, eliminate gingival bleeding, infection, and reduces periodontal pocket and mobility, stops pus formation, arrests the destruction of soft tissue and bone, establish optimal occlusal function, restores tissues destroyed by the disease, re-establish the physiological gingival contour, prevent recurrence of the disease, reduces tooth loss. So, before you are doing a periodontal therapy, you should know what are the objectives. First, you remove the pain, then stops the bleeding, then you just take care of the gingival contour. After that, go to the periodontal ligament, arrest the destruction of the soft tissue, then arrest the bone loss. Once you do all these things, automatically the tooth loss will be prevented. Okay? That must be your objective. Now we should know factors that affect healing. So when you are thinking about the factors that affect healing, you can take it into two things. One is with a local factor, other one is with a systemic factor. So local factors, the healing is delayed due to contamination of the microorganisms, irritation from the plaque and food debris, necrotic tissue remnants, trauma from occlusion, trauma to the tissues, excessive tissue manipulation during treatment, repetitive treatment that affects cellular activity in healing process, and topically applied cortisone and ionizing radiation. So the healing is delayed due to the first thing they say is contamination of the microorganisms. That means by doing a surgery or whatever the treatment in an aseptic manner, the healing will be better. Number two, irritation from the plaque and food debris. Already I told you, plaque is more irritating than the calculus. So if the plaque remains, like when you are doing a surgery, if the subgingival plaque remains, naturally the healing will be affected. And then necrotic tissue remnants. Here you should understand the necrotic tissue remnants can be in the cementer side, root side, as well as the lateral wall of the pocket. So when you are removing the granulation tissue and the necrotic cementer from the root surface, you are giving a fine environment for the tissue attachment. If the necrotic tissue remains the same, again the healing will be affected. Trauma from occlusion and trauma to the tissues. Already I told you, trauma from occlusion, it is a tissue injury. Without clearing the tissue injury, what is the point you are doing a surgery? So first elevate the trauma from occlusion, then go ahead with the surgery if you have a better healing. And then excessive tissue manipulation during treatment. This means when you are doing a surgery, you will be approximating with the suture material. If you give excessive manipulation, there is a tear in the tissue or the flexibility goes out, again the healing will be affected. And repetitive treatment that affects cellular activity and healing process, and topically applied cortisone. Already this steroids will affect the healing, isn't it? So why these local factors stops the healing? These are the reasons. Then how to improve the healing then? You know what is the reason for healing? Impaired healing. Now you should know how to improve it. Local increase in temperature, debridement, immobilization of the healing area, pressure on wound. So the healing will be improved by local increase in temperature. And second thing, if you do a proper debridement, removal of plaque, calculus, material, everything, okay, and debris, all other things. And immobilization of the healing area. See, usually when you are doing a flap surgery, you will give a suture, you will give a pack. The pack not only protects the surgical area, it also acts like a splinting so that the immobilization will be there. Healing will be better. And then pressure on the wound. All those things will improve the healing. Okay. Systemic factors. So till now we read about local factors, now systemic. Healing is delayed in aging, that you know, isn't it? And generalized infection, diabetic, insufficient food intake, vitamin C deficiency, deficiency of protein, other nutrients, increased level of hormones, systemic stress, all other things. So aging, already you know the healing will be impaired. And then generalized infection and diabetics and other debilitating diseases. Why there is an infection delayed in diabetics? Because the vessel wall get thickened. You won't have a proper blood circulation to that area. Unless there is a circulation is proper in that area, recruitment of cells will be minimal. So the healing will be affected in a diabetic patient. Insufficient food intake, Vitamin C is very, very important for the collagen formation, isn't it? So that is getting impaired because of the vitamin C deficiency. Deficiency of proteins, increased level of hormones and systemic stress and other things. So now the healing delayed in systemic factors, these are the points will come out. Healing after periodontal therapy. Here you should know what is regeneration, what is repair and what is new attachment, what is reattachment. Regeneration, biological process by which the architecture and function of the last tissues are completely restored by the formation of new periodontal ligament, alveolar bone, cementum. What this is there will be a attachment apparatus fully newly formed. Okay. So that is why in regeneration we are using GTR and graft because newly formed tissues there. Okay. Repair, healing of tissue without completely restoring the last tissue. See, repair is healing of tissue without completely restoring the last tissue. For example, after there must be a recession in that area, after doing a scaling, inflammation in that area will be reduced, but it is not going to get back to the CE junction. That there is only a repair. Whereas if you do a GTR or graft, you will get restoring the tissue to the CE level. Say that is regeneration. So you should know what is regeneration. Given the repair will be there, the last tissue lost is lost only. Whereas in regeneration, all this attachment apparatus will be regenerated. And new attachment and reattachment. Now, new attachment. Reunion of connective tissue with the root surface that has been pathologically exposed. New attachment, reunion of the connective tissue with the root surface that has been pathologically exposed. When the root surface is pathologically exposed, apart from that, recession can be even physiological. Periodontal pocket, isn't it? In the pocket, the root is pathologically exposed to connective tissue, granulation tissue and microorganism, isn't it? There is a new attachment. Now, reattachment, reunion of connective tissue and the root surface that have been separated by incision or injury. If it is pathologically exposed and treated, you will get new attachment. When you are doing the incision or injury, they are getting attachment is reattachment. So you can say even in a flap surgery, you are doing incision. You are separating it, then you are cleaning it. Approximating it, isn't it? So you should know what is new attachment, what is reattachment. Reattachment, it is by means of incision and injury, whereas a new attachment, pathologically exposed root surfaces reunited. Okay. So now you should know what is regeneration, the last tissue are completely restored by the formation of new alveolar bone, periodontal ligament and other things. Repair, healing of tissue without completely restoring the tissue. And what is new attachment is reunion of connective tissue with the root surface which is pathologically exposed, and reattachment, reunion of connective tissue and root surface that have been separated by incision or injury. Till now is it okay? Now, see the periodontal instruments. Okay, EP plate is there, Kirkland is there, Ormans is there, Curers are there, periosteal elevator, everything is there. Now, what are the surgical instruments? Excisional and incisional instrument, surgical curettes and sickles, periosteal elevator, surgical chisel, surgical files, scissors, chemostats and tissue forceps. See, periodontal knives, gingivectomy knife, Kirkland knife, 15 and 16 is commonly used for gingivectomy. In orals, they can ask you what is the instrument used for gingivectomy. It is a Kirkland, the number is 15 and 16. They can ask you in the MCQ. And interdental knives, Orban knife, Merrifield knife. So usually you people know only about Orban's knife. Please remember there is one more knife which can be used as an interdental knife, that is Merrifield knife 1, 2, 3, 4. These are the gingivectomy knives. Crane Kaplan pocket marker. See what they are doing with the Crane Kaplan pocket marker. Just they are marking the pocket level, how long, depth of the pocket. Usually in suprabony pocket, in case the enlargement is non-inflammatory, then we will do a gingivectomy, gingival enlargement, idiopathic gingival enlargement, false gingival enlargement, all the things we will be doing a gingivectomy. when we are doing a gingivectomy, we should be very careful. We should not hurt the bone below it, isn't it? So just to avoid that, you take the Crane Kaplan pocket marker so that it will mark the pocket, the level of the pocket which is to be eliminated. These are the surgical blades. The most commonly used blades in gingivectomy, they are 12D, 15, 15C. 12, they can give 12, 12C, 12D, 11. So you should know to tick 12D, okay. 15 and 15C is also used for the flap surgery. So the main thing is 12D. Periosteal elevator. It is used to separate and retract the soft tissue from the teeth and bone. When you are elevating the mucoperiosteal flap, that is a full thickness flap, we always use a periosteal elevator which will separate the bone and the teeth. So what are the numbers? Mold 9, Woodson and Pritchard elevator. Mold 9, Woodson and Pritchard elevator. Why I am giving this name is, sometime in MCQ they will ask you. Mold 9 means you should not think what it is. It is only the periosteal elevator. Mold 9, Woodson and Pritchard elevator. Most of them we are using Mold 9, isn't it? See the first elevator. Usually we are using that. These are all bone curettes used to remove debris from the bone, bony defect during surgery. This is bony curettes. Ranger forceps designed to cut and remove the bone. This they can ask you in MCQ. The use of Ranger forceps, they will give 4 things. The main thing is designed to cut and remove the bone. And bone file used to smooth the alveolar bone. You should know the difference between Ranger forceps and bone file. Bone file is just to smooth the ledgers, craters, thin bony margins. It will only smooth, it is a file. Whereas Ranger forceps will cut and remove the bone. Surgical chisels and hoes used during periodontal surgery for removing and reshaping the bone. See, I want you to understand the surgical file, it is only smoothening the bone, whereas reshaping and removing the excess bone can be done by means of surgical chisel. Now you understand the difference between chisel and the file, is it okay? Ocean Bean 1 and 2 is a surgical chisel. This is a surgical file used primarily to smooth rough bony ledges and to remove all areas of bone, that is Sugar's file. See the file? See now I want you to say, you shouldn't get between this file and one more file first time I showed you. Bone file. See this bone file, this is only smoothening. You should know the difference. This is only smoothening. Whereas this file remove the rough bony ledges to remove all areas of the bone. Okay, see the file how it is. Sugar's file 9 and 10 is the usual number. Surgical scissors used to excise soft tissue. When we will use this surgical file, when we are doing a flap surgery to remove the hanging tissues, because that tissues will we will do the healing impairing. So to stop the impaired healing because of the hanging tissue, they will use this surgical scissors so that they can trim the inner side of the flap and thin the outer side of the flap. Okay, and suture needle holder, it is used to hold and manipulate the suture material. Know the difference between conventional needle holder and Castrovillo needle holder. Usually that needle holder when they will use means when you are using 60 or 50 black silk, when you are doing a regeneration therapy, when you are doing a periosteal suturing, that time you can use that instead of this conventional needle holder. That is the difference. Okay, Castrovillo needle holder can be used in regenerative therapy because you will have a thin tissue, isn't it? That time you cannot make use of this conventional needle holder. That time you can use that needle holder. Now, what are the principles of periodontal instrumentation? instrumentation. Proper patient position, proper operative position, illumination should be there, sharp instruments and stabilization of the instruments. Types of stroke, placement stroke, exploratory stroke or assessment stroke, scaling stroke, route planing stroke. You can ask why there are so many differences. Route planing stroke will be an obligatory stroke, okay, and scaling stroke will be a short, powerful pulling stroke, okay. Then exploratory stroke and assessment stroke can be used in the curettage also. And placement of stroke, you should know where to use a pull stroke, where to use a push stroke. Pull stroke we will be using when we are using a universal scaler, anterior scaler and posterior scaler. Push stroke we will use only when we are using a chisel scaler. Where we will use a chisel scaler? Only in the mandibular anterior area. Understood? That is why there are 4 types of strokes are given there. Now we should know non-surgical therapy. Scaling, it is a process by which plaque and calculus are removed from both supragingival and subgingival tooth surface. It is only a removal of plaque and calculus. Route planing, process by which residual embedded calculus and portion of the cementum, what cementum? Necrotic cementum, are removed from the roots to produce smooth, hard, clean. Okay, root planing will give smooth, hard and clean surface. It will remove the embedded calculus and necrotic cementum on the root surface. Whereas scaling is just removing the plaque and calculus from the supra and subgingival calculus. That doesn't remove the embedded calculus. That is the difference between root planing and scaling. And these are the different surgical procedure. Gingivectomy. The periodontal plastic surgery includes crown lengthening, ridge augmentation, periodontal prosthetic correction, aesthetic surgical correction, coverage of denuded root surface, reconstruction of papilla. All those things will come under periodontal plastic surgery. Plastic surgery is done mainly for aesthetics. Types of suturing. Here, interrupted suture, that will include simple loop suture, figure 8 suture, sling suture. These are all interrupted sutures. Whereas continuous suture, in that independent sling suture, independent sling with horizontal suture. They can give figure of 8 suture. Then you should write it is an interrupted suture. Okay. So continuous sutures, interrupted, independent, sling suture and sling with the horizontal suture, matrix suture, and distal wedge suture, closed anchor sutures and periosteal sutures. We will use distal wedge sutures in the mandibular molars, posterior. Okay. Especially after the 8. That after the 8, usually after doing a flap surgery, around the 8, either you should do curettage, otherwise you should make a wedge-shaped incision and suture it, so that recurrence of the pocket posterior to the 8 will be arrested. Okay. So, distal wedge sutures in Keta, you should know, wow, duty. Distal wedge sutures in mandibular and maxillary 3rd molars. Okay. Closed anterior suture, periosteal sutures. So, these are the different type of sutures. See where the suture should be. The suture should enter and exit the papilla at the point located below the base of an imaginary line triangle in the papilla. See, they have written, they have given the triangle, isn't it? See, these are all, and it is the imaginary line. See, where the suture points are there only they will enter and exit the suture material. Okay. So, suture should enter and exit the papilla at the point located below the base of the imaginary triangle in the papilla. See, now simple loop suture. It permits better closure of the interdental papilla. The interdental papilla should be tightly closed because the blood circulation is from that area alone. So, it has to be, whenever you are giving a suture in the interdental area, put your finger and give a pressure. Otherwise, that area will get necrose. You won't get a proper healing. Also, when close approximation of the flap is required, see the suture material and the last here, where the suture enter and exit, it is written in a points. See there whether it is the same. Is it so? Isn't it? To close the interdental papilla, and for the approximation of the flap, we will be using a simple loop suture. See this figure of 8. Presence of threads between the flap, used when flaps are not in close opposition. It is simple to perform. You are able to understand the simple loop on this? See, it is presence of thread between the flaps, between the two flaps, and used when the flaps are not in close opposition. You have to tightly put it and then do it, and then simpler to perform. This is an interrupted sling suture. So, interrupted sling suture will come under what? Interrupted sling suture. See, it can be used for a flap on one surface of the tooth that involves two interdental spaces. See this? Usually in periodontal therapy, where we will do now, sometimes the bone loss will be more in a buccal area, and lingual or palatal area there won't be any bone loss at all. So to arrest the bone on the buccal area, we will raise the flap. Whereas because in the palatal lingual there is no bone loss, so why to raise the flap? We will do curettage in that area. Here we will raise. So that type, where the flap surgery and curettage is combined on the segments, we can do this interrupted sling suture. So that is what they are given. See in that area, there it is not given. See, the suture goes from here and around the tooth and then comes out, then comes out. They are not piercing on the lingual or a palatal side. Are you able to understand? So one side there is only a curettage. This side we are raising the flap. So without raising the flap on the lingual or palatal area, why to pierce the needle? So we will do like this. See, take the thing, it will go around the tooth and it will come out, and then they will give a thing, then they will give a knot here. So on the palatal lingual area there will be a around the tooth. There won't be any, yes, there won't be any bite at all. So it can be used for a flap on one surface of the tooth that involves two interdental spaces. This is interrupted sling suture. See this is a continuous sling. You remember sling means the suture around the tooth. Okay. So interrupted sling la vandu modala enna aachu nama pottadula only one side of the tooth. Whereas inge paru both the side it is covered. Okay, this is continuous sling suture. Now periosteal. So periosteal suture only you should be very careful because blood supply is there, so more of bleeding will be there in the periosteal suture. Used to hold in place apically displaced partial thickness flap. When will we do apically displaced flap? To increase the width of the attached gingiva. We will do that apically displaced. So periosteal suture used to hold in place apically displaced partial thickness flap. There are two types there, holding sutures and closing sutures. So only the periosteal sutures will have two types. All other sutures are different one. And then periosteal itself there are two types there. One is holding suture to hold the periosteum in place, and other one is closing sutures. Krishna, what is holding suture and otherwise a closing suture? Holding sutures, horizontal matrix suture that secures the flap in new position. It is a horizontal matrix suture. It will secure the flap in a new position, is a holding suture. Closing secures the flap edges to the periosteum. Understood? Periosteal suture is a suture. It used to hold in place apically displaced partial thickness flap. There are two types as there, holding sutures and closing sutures. When a holding sutures is a horizontal matrix suture which will hold the periosteum in a new position, whereas closing is secures the flap edges to the periosteum. Are you thorough about the periosteal suture? No. See this placing suture. Before I told you, holding horizontal matrix secures the flap in new position and secures the flaps to the periosteum. These are the two type of things. Understood? Holding and closing. Okay. This is the two type of sutures. Surgical techniques. curettage. Nowadays we are not using the word called curettage, we are using a word called scaling and root planing. So curettage means scraping of gingival wall of the periodontal pocket to separate dead diseased soft tissue. Scaling refers to the removal of deposits from the root surface. Planing means smoothing the root to remove the infected and necrotic tooth substance. There are types of the subgingival curettage and inadvertent curettage. Subgingival curettage refers to the procedure that is performed apical to the epithelial attachment, whereas inadvertent refers to some degree of curettage which is done unintentionally, not intentionally, unintentionally. When there is a gingival inflammation is there, gingivitis is there, patient is complaining of bleeding, all those things we will be doing SRP, that means scaling and the root planing. Whereas in inadvertent, it is not done intentionally, it is unintentionally done, which is done unintentionally when scaling and root planing procedures are performed. See, gingival curettage or subgingival. The A is gingival curettage, and that goes subgingivally, subgingival curettage. Okay? Indications, when and all you will do. Curettage can be performed as a part of the new attachment. What did I tell about new attachment? Pathologically exposed, where the reunion of tissue takes place when there is a pathologically exposed root surface. So here the curettage can be performed as a part of the new attachment when a closed surgery is advisable. When you will need a closed surgery in case the patient is having some systemic problem, where there is no chances for raising the flap, at the same time you have to reduce the gingival infection and inflammation, that time we will do a curettage. And can be done when flap surgeries are contraindicated. When it will get contraindicated, old age, very old, and then systemic problems, there are some endocrine problems, diabetic is there, bleeding disorders are there, and then psychological problems. I told you already, systemic factors which will impair the healing. I told even endocrine problems and stress and all other things. And curettage is performed on recall maintenance visits where recurrent inflammation and pockets are present. Okay. So why there is a recurrent inflammation pockets? Because already existing disease is there. At the same time, we are not able to do a flap surgery because of factors which includes impaired healing some more. That time you will do recurrent curettage and you call the patient on a recall interview to maintain the gingival health. Procedure, basic technique, excisional new attachment procedure, ultrasonic curettage and caustic curettage. Here you are supposed to give more importance on caustic because all these things you are very familiar in the department, you are doing it. Caustic curettage we are not doing, at least you should know what are the medicines which is used to do a caustic curettage. These are the cures. There you see elimination of the pocket lining, elimination of the junctional epithelium and granulation tissue, procedures completed. See after the curettage how it is. See here. See they are eliminating the pocket lining. This is the pocket lining, isn't it? And they are removing the junctional epithelium and granulation tissue. And once it removes, it will be like this. So this pathologically exposed root surface will get united with the lost tissue. Okay, this is how we will know. Now, caustic drugs. This they can ask you in the MCQ. What are the drugs which can be used? Here, use of caustic drugs to induce a chemical curettage as a lateral wall of the pocket or even the selective elimination of the epithelium. What do you understand by this selective elimination? What do you understand by selective elimination? They have written selective elimination of the epithelium. Sulcular epithelium, junctional epithelium, then surface epithelium. Why we are saying this all three epithelium? Why they are using the word selective elimination of the epithelium? Pocket lining, which contains gingival epithelium, sulcular epithelium, and then junctional epithelium, surface epithelium. Why we should give three epithelium and why to say, we can just say epithelium, because this sulcular epithelium this sulcular epithelium will heal by 5 days, isn't it? Generally we will say the epithelium heals by 7 to 14 days, am I? Isn't it? So many times I used to say that is the thing. So sulcular epithelium will by 5 days, junction will become 5 to 7 days, surface epithelial will become 7 to 14 days. That is why the word selective elimination of the epithelium is given. Now you are clear? Clear, Aisha? Here, sulcular epithelium, elimination of the pocket lining, and here elimination of the junctional epithelium, and then finally surface epithelium. Adanaladan, they have given the word selective elimination of the epithelium. Generally, they say the epithelium heals by 7 to 14 days, as because the sulcular epithelium heals by 5 days, junctional by 7 days, and oral surface epithelium by 7 to 14 days. Or is it clear now? Then, drugs like sodium sulfide, alkaline sodium hypochlorite solution, and phenol, these are the things can be used. They can give in MCQ the caustic drugs used for chemical curettage, either sodium sulfide, alkaline sodium hypochlorite solution, otherwise known as antiformin, and phenol. These are the drugs. Okay? And disadvantage is the extent of the tissue destruction cannot be controlled. That is the reason we are not using a caustic curettage. In case they ask me what is the date, they can put the caustic curettage is not used nowadays. Maybe because you cannot control how much depth you can control. With the BP blade, with the curette, you will be knowing where you are, the tip of the instrument aims. Caustics you cannot. So, destruction of the tissue cannot be controlled. Is it understood? Can I go to the next slide now? This is a gingivectomy. See? Excess gum forms pocket. This is excess thing. Excess gum tissue is removed. Okay? Suprabony pocket. This is above the CE junction, above the crest of the alveolar bone. We call it as a suprabony pocket. This can be removed. Excess gum tissue will be removed by the gingivectomy procedure. Okay? Please stop me where you are not able to understand. Gingivectomy is performed to eliminate periodontal pockets and includes reshaping as a part of the technique. So, gingivectomy eliminates the suprabony pocket, then only reshaping it. Directly is just not reshaping it. Eliminates the suprabony pocket. Gingivoplasty is a reshaping of the gingiva to create physiological gingival contour. When you say gingivectomy, you can see the suprabony pocket, suprabony pocket. For example, gingivectomy can be done in a gingival enlargement, inflammatory, non-inflammatory condition, drug-induced, everything. Whereas gingivoplasty will be done when there is a gingival abscess. Because the gingival abscess is confined to margin of the gingiva. After removing the pus, the gingival tissue is going to remain the same. There is not going to be the pocket also. So, that can be reshaped by means of gingivoplasty. You have understood now? Just between gingivectomy and gingivoplasty. This eliminates the periodontal pocket and includes reshaping as a part of the technique is gingivectomy. Gingivoplasty is just reshaping the gingiva. So, in case they will write recontouring of the gingiva in absence of for a pocket, then automatically you should write up a gingivoplasty. What are the indications for gingivectomy? Elimination of suprabony pocket regardless of the depth if the pocket wall is firm and fibrous, and elimination of gingival enlargement, elimination of suprabony periodontal abscesses, crown lengthening, and perioaesthetic procedures. All those things there will be a gingivectomy. So, I already told you elimination of suprabony pocket and elimination of gingival enlargement, any type of inflammatory, non-inflammatory, drug-induced, idiopathic, any type of gingival enlargement, and elimination of suprabony periodontal abscess also, isn't it? And then crown lengthening. When there is a need to put a bridge, when they need to have an interdisciplinary work, the crowns are very small, they need a sufficient tooth structure to hold the prosthetic procedure. We will do the crown lengthening. And then perioaesthetic procedure. All those things we will be doing a gingivectomy. Then when you won't do need for bone surgery or elimination of bone shape and morphology. That means the gingival enlargement is there, at the same time the patient is having a bony defect. Can you say one disease where you will have such combination? Patient and the cyclosporin therapy, most of them they will have a pocket formation, at the same time gingival enlargement will be there. That time you just can't do gingivectomy alone, you have to join with the flap surgery. So that is one contraindication. And bottom of the pocket apical to the mucogingival junction and aesthetic concentrations, particularly in the anterior maxilla. These are the things contraindicated. Okay. Here what point they will give in MCQs, usually they will give the second point. Bottom of the pocket apical to the mucogingival junction. They will put gingivectomy, gingivoplasty, flap and all other things. You should go ahead with the flap. That is not, so bottom of the pocket, if it is apical to the mucogingival junction is there, you should not do a gingivectomy. So what is the instrument used for gingivectomy technique? Pocket marking probe. I already told you the name of the pocket marking probe is? Right. And here, see, it is exclusively during gingivectomy for determination of the base of the periodontal pocket. Why means only the suprabony pocket can be marked over there. If it is goes below, definitely the Crane-Kaplan pocket marker won't go below that. Okay, ma? See, after the gingivectomy, see how the healing takes place. The initial response is the formation of protein. Immediately what comes is clot. Why they are giving more importance for the clot? It contains growth factors. It has platelet derived growth factor AA and BB. Apart from that, they will have vascular growth factor. These are very important for the healing. So immediately the first thing which comes in your mind should be a clot. Okay. And then it becomes acutely inflamed with some necrosis. The clot is then replaced by the granulation tissue. Usually they will ask what is the difference between the granulation healthy and this thing. It will have a just small tiny sprouts will be there, and it will be, I mean that disease granulation will be, the color will be bluish red, where this will be red because of the amount of capillaries which contains vascular growth factor. There will be more of circulation. And then by 24 hours, there is increase in new connective tissue cells, and here also mainly angioblasts. Third day, numerous young fibroblasts are located. Then capillaries derived from the blood vessel or periodontal ligament migrate into the granulation tissue, and within 2 weeks, they connect to the gingival vessel. So main thing here, the usual question comes is the initial response, what it will be there? Mainly blood clots. 5 to 14 days, surface epithelialization is generally, that's why I am repeatedly saying, you put in your mind 7 to 14 days is the epithelialization. In gingivectomy, 7 to 14 days. Why we are giving 5 days here? Because the sulcular epithelium also removed, isn't it, for that? And then during the first 4 weeks after gingivectomy, keratinization is less than it was prior to surgery. That also you mark it out, no? Because usually they will ask, when will be the keratinization takes place after the gingivectomy? Complete epithelial repair takes about 1 month. Vascularity began to decrease after 4th day of healing. Complete repair of connective tissue 7 weeks. So these are the points you should remember. 5 to 14 days surface epithelialization. Complete repair of the connective tissue takes about 7 weeks. Maximal flow of gingival flow is reached after 1 week, coinciding with the time of maximal inflammation. Is it okay? Now, gingivectomy by electrosurgery. There is an instrument called electrocautery. It will have different type of loops. With that, they will cut the excess gingival tissue. So usually gingivectomy will be done not only by the BP blade, also by means of chemicals and electrosurgery, otherwise by means of electrocautery, and fourth one is by means of laser. Okay, this is electrosurgery. Advantage: electrosurgery permits an adequate contouring of the tissue and it controls hemorrhage. This point is very important here. When we are doing with a BP blade, definitely there will be a bleeding. Whereas when you are doing with an electrosurgery, electrocautery, this is actually, Gingivectomy by means of electrosurgery, the instrument used is this. It permits an adequate contouring of the tissue and it controls hemorrhage. So, only advantage is here is it controls the hemorrhage. What are the disadvantages? You can't use for the patients with a cardiac pacemaker, isn't it? And the treatment causes an unpleasant odor. Why this unpleasant odor comes? Necrosis. If the electrosurgery points touches the bone, irreparable damage can be done. Okay? And when the electrode touches the root, areas of cementum burn are produced. So, with all this disadvantage, we are doing only with the scalpel technique, we are not doing the electrosurgery, but in our department we have electrosurgery unit. One is, you cannot use for the pacemaker, and second thing, it will give an unpleasant odor. When it goes with the bone, it touches the bone, there will be an irreparable damage. The bone cannot be replaced again. Why the bone cannot be replaced? Because the osteoblast will die off, isn't it? Necrosis. And then if the electrode touches the root, areas of the cementum burn or produced. So, there is a chance for asking when the cementum burn will produce. They will put cementum burn will be produced 1, 2, 3. If a point is there on electrosurgery, please tick that point, you will get a mark. Okay. Then this is the laser gingivectomy. The laser most commonly used in the dentistry are carbon dioxide and Nd:YAG. Please remember, these two lasers are commonly used. They can ask you in MCQ. The use of laser beam for oral surgery requires precautionary measures to avoid reflecting the beam on the instrument surface. We will give importance for this Nd:YAG. Okay, with a wavelength of 10,600 nanometer and 1064 nanometer respectively. So, if you are the carbon dioxide laser wavelength is higher than the Nd:YAG. So, you remember that. The wavelength of carbon dioxide laser is higher, 10,600 nanometer, where this is only 1064 nanometer. Then gingivectomy by chemosurgery. Techniques to remove the gingiva using chemicals. This is 5% paraformaldehyde or potassium hydroxide have been used. This is not at all recommended. Again, here also you won't know the depth. The depth of the action can be controlled. Gingival remodeling cannot be accomplished effectively unless you know the depth, unless you know the idea to trim. How can you control it, isn't it? So, this cannot be used. Osseous surgery, defined as the procedure by which changes in the alveolar bone can be accomplished to get rid of these deformities induced by the periodontal disease or other related factors such as exostosis and tooth supraerection. So, usually when we will do osseous surgery, wherever there is a need for correction, okay, exostosis is present, automatically there will be a difficulty in speech, sometimes the tongue movement is restricted, more accumulation of other food materials, that time you will be doing a osseous surgery. The type of osseous surgery, depending on the relative position of the interdental bone to the radicular bone. So, this osseous surgery in periodontics, in dentistry, when we will do is, it is depending on the relative position of the interdental bone to that of the radicular bone. Sometimes, what do you understand by this? Sometimes the bone which is covering the root is below the CE junction and correct interdental thing. Naturally, we will say buccal bone loss is present. Yes or no? Isn't it? And buccal side and lingual side or palatal side, the bone is exact. At the same time, it is reduced in the interdental area. Naturally, what we will say, crater is present. Okay. And labial wall and lingual wall is there. Labial wall and palatal wall is there. At the same time, between the two walls, there is no bone. Again, there will be a crater. Both the walls will be there. There will be a crater, isn't it? So, always how they will see whether the case will go for an osseous surgery or not depends on the relative position of the interdental and the radicular bone. Understood? Now, positive architecture, negative architecture, flat architecture and ideal. All these are different surgeries. depending on the thoroughness of the osseous reshaping, definitive osseous reshaping, compromise osseous reshaping, depending upon the restoration, additive or subtractive. These are all depend upon the resective osseous surgery, when we will remove, when we will do resection. Indications: one-walled angular defect and thick bony margins and shallow crater formation. Here and all you can just remove, resect the bone, you will get it to the normal contour, isn't it? And contraindication, anatomical factor, systemical, all these things will be the same as that of the indication is one-walled angular defect. What do you understand by one-walled? One wall is present, all others are missing, isn't it? Right. And thick bony margins and shallow crater formations. What are the techniques you will use? Vertical grooving, radicular blending, flattening of the interproximal bone and gradualizing the marginal bone. These are the different steps what we are using for osseous, resective osseous surgery. This is used only for resective osseous surgery. Vertical grooving, radicular bending, flattening of interproximal bone and gradualization of marginal bone. Why you need a gradualization of marginal bone? Only then the attachment, thin flap will get attached properly, isn't it? How the healing takes place after I told you first gingirectomy healing, clot formation will be there, then only the connective tissue and then only angioplasty. Then 5 to 14 days, and keratinization will take a long time than the other surgeries. The same way you should know what is how the healing takes place after the surgery. Initiation of inflammatory response, necrosis of the alveolar crest, osteoclastic resorption of the bone, then only repair and remodeling. Direct repair and remodeling it won't. First there will be a initiation of inflammatory response and then necrosis of the alveolar crest, then osteoclastic resorption of the bone, then repair and remodeling. This is the usual procedure how it takes place. All these times we read about resective osseous. Now reconstructive. This is types non-graft associated new attachment, graft associated new attachment, combination of both. Already I told you new attachment is getting the last tissue to the original position where there is a pathologically exposed root surface. Other clear panna pirpaadu with the surgery what you are getting is a new attachment. With the incision injury what you are going to get is a reattachment. And here reconstructive surgery types non-graft associated. When you will do a reconstructive osseous surgery? I told you here, no? எப்போ பண்ணுவீங்க reconstructive? Additive. Definitely osseous reshaping you want. And when there is going to be a restoration of bone, reconstructive, additive. Okay? Now, non-graft associated new attachment. What do you understand by non-graft associated new attachment? அப்போ என்ன பண்ணலாம்? Non-graft associated. You know the answer. Get it out? Right. Ilya? GTR you can control your long junctional epithelium, isn't it? There is no need for the graft, bone graft. So non-graft your mind should go on a GTR. Okay. So new attachment can be achieved without graft. Meticulously treated 3-wall defect. There's an abscess which combined with the periodontal and endothelial. And when the destructive procedure has occurred very rapidly, these are the things. And procedure, removal of junctional epithelium, prevention of epithelial migration. So prevention of epithelial migration, you will understand presence of GTR is more important. Okay, ma? Clot stabilization, wound production and space creation, preparation of root surface. So these are the procedures. Now new attachment can be achieved without graft is by means of GTR. The only question can come here is non-graft associated vandale, your mind should go for a GTR. Graft associated new attachment. These are the types of graft: xenograft, allograft, autograft and alloplastic material. So when you are giving this graft, then you should know what is osteoinduction and what is osteoconduction. osteoinduction process by which the graft material is capable of promoting cementogenesis, osteogenesis and new periodontal ligament. All formation, genesis will be there in osteo. It induces, it stimulates, okay. And osteoconduction, graft material acts as a positive matrix, okay. It acts as a positive matrix like a trellis or scaffolding of a, for a new bone to cover. It will just present there, over that it will act like a scaffold, over that the bone formation will be there. Whereas osteoinduction, the graft itself will induce formation, okay ma? That is induction. Conduction is, but it will act like a scaffold over that where the bone formation will be there. Are you able to understand between the induction? Induction only genesis, formation, cementogenesis, alveologenesis like that. Where is your scaffold? Then contact inhibition, process by which the graft material prevents apical proliferation of the epithelium. This is contact inhibition. Inhibit, it prevents it from getting contact, that is contact inhibition. Process by which the graft material prevents apical proliferation of the epithelium. Sometimes you will do graft plus GTR together, contact inhibition, okay. Guided tissue regeneration, an epithelial exclusionary technique that promotes new connective tissue attachment without the use of any implant material. Anga or graft theva kadiyadu, okay. What is bone blend? This they can ask you in MCQ. It uses an autoclave plastic capsule and the vessel. Bone is removed from the predetermined site with a chisel or a Ranger forceps, placed in a capsule with a few drops of saline and triturated for 60 seconds to a workable plastic-like mass and packed into the bony defect. See, bone blend is nothing but you take a bone from the already planned site. You take it and put it in a capsule. Then add few drops of saline. Nicely triturate for 60 seconds. What you are getting, the plastic-like material is called bone blend. So you remember like the bony chips blended together. So plus saline, put it and you know like in amalgam you do not pre-mixed amalgam. It will be like a capsule, you do like this, you get a putty like consistency, you pack it up. You remember that it is a bone blend. Like same way here the bone is removed from the predetermined, inga irundha nama bone edukrom nama plan pannidom, predetermined site, and then add 2 to 3 drops of saline and triturate for 60 seconds and you will get a material which can be used as a graft is bone blend. Why I am giving more importance for this bone blend is most of the time you people are not knowing the difference between osseous coagulum, bone blend and bone swedging. For that only I am giving more importance. Bone blend is like this. You remember bone blend. The bone chips are blended. Blended with what? Saline. Triturated with 60 seconds you will going to get a material which can be used like a graft. Understood? Then now see this bone swedging. These two difference you should know well. Here an edentulous area adjacent to the defect. Anga vande predetermined site. Whereas here edentulous area adjacent to the defect from which the bone is pushed into the contact with the root surface without fracturing the bone at its base. Anga vande you will remove the bony chips. Inga appadi kedaiyadhu. Bone swedging, that means pushing, swedge pandrathu, like rendu idu onna sekiradhu. See, an edentulous area adjacent to the defect from which the bone is pushed into contact with the root surface without fracturing the bone surface. Ippadi irukna ippadi kondu poporinga without affecting the base. Here there is a defect, edentulous area is nearby. You are going to push this bone adjacent to the root surface without disturbing the base. You are able to understand bone swedging and bone blending? This is GTR. See how the GTR is used here. There is a defect, isn't it? They are going to prevent the apical migration of the junctional epithelium. So after doing flap surgery and everything, this area they are taking the GTR membrane, they are going to tie it up directly like this. So it prevents a further migration of the epithelium, isn't it? Apical migration of the epithelium is more, naturally you will get the pocket. by means of GTR it is arrested. You have understood this? GTR is based on the principle of placing a barrier membrane to cover the bone. See, it has covered the bone, and periodontal ligament thus temporarily preventing the down growth of gingival epithelium and connective tissue cells. You are able to understand now GTR? Now mucogingival surgery. Periodontal surgical procedure designed to correct the defect in the morphology, position and amount of gingiva surrounding the tooth. See? Periodontal surgical procedure designed to correct the defects in the morphology, position and amount of gingiva surrounding the teeth. Can you say one mucogingival surgery now? Remember the word, correct defects in the morphology, position. Phrenectomy, phrenotomy, isn't it? Vestibuloplasty. Don't you think that and all correcting the mucogingival morphology, position and the amount of the gingiva? Phrenectomy, phrenotomy, increasing the width of the attached gingiva, vestibuloplasty, all these things will come under mucogingival surgery. See, periodontal plastic surgery. Surgical procedures performed to correct or eliminate anatomic, developmental or traumatic deformities of the gingiva or alveolar mucosa. Can you say anything? Surgical procedure performed to correct or eliminate anatomic, eye frenal attachment, developmental, gingival retreat. What is gingival retreat? What is gingival retreat? Not heard that word? See, during the developmental stage, the gingiva, the marginal gingiva has to go back to the CE junction. If this gingiva is not retreated back, what will happen? You will have a square shaped tooth. The excess gingiva will be there. Look here. This is a tooth, isn't it? The gingiva, marginal gingiva is going to be in the CEJ. If this is not receded to the normal position, imagine this is the gingiva. What will happen? Your teeth will become like a square shaped teeth. It loses its morphology. So you remove this excess, then you will have a normal contour. If the gingiva is not receded to the CE junction, that is called gingival retreat. That it is actually a developmental anomaly in the gingiva. Mucogingival problems. Pocket extending up to or beyond the mucogingival junction. I told you when I am giving a contraindication for gingivectomy, I told you pocket extending above the mucogingival junction, you cannot do gingivectomy, isn't it? So recession causing denudation of root surfaces, high frenum and muscle attachment, and inadequate width of attached gingiva. All these things will come under mucogingival problem. That's why I told you when there is an inadequate width of attached gingiva, we will increase the width by means of vestibuloplasty, and frenum and muscle attachment will do phrenectomy or phrenotomy according to the condition. When the recession causing denudation of the root surfaces, we will do lateral reposition flap or free gingival graft, otherwise subepithelial connective tissue graft to cover the denuded root surface. Pocket extending up or beyond the mucogingival junction, most of them in case it extends to a particular level, sometimes we do even the coronally reposition flap, very rarely. Okay. This is the flap. The periodontal flap surgery, we can divide the flap into two things. One is mucoperiosteial flap, otherwise known as full thickness flap. Other one is partial thickness flap, otherwise flap with the periosteum, split thickness. Okay. The section of the gingiva or mucosa surgically separated from the underlying tissue to provide visibility and access to the bone and the root surface. Why we are doing a flap surgery? So that we will see the necrotic cementum. We will see any embedded subgingival calculus is present. Any granulation tissue is still attached to the lateral wall of the pocket. The main idea of doing a flap surgery is just to have an access for the instrumentation and to have the visibility. Okay, they will do the surgery for a better access and visibility. Gingivectomy, flap surgery, phreniectomy, like that they'll put. You should correct flap surgery. Flap surgery is only to get the excess and visibility. These are the classification of the flap. Based on the bone exposure, after the flap reflection, full thickness or partial thickness. Full thickness is otherwise known as mucoperiosteal flap. And based on the placement, non-displaced or displaced. Displaced, apically displaced, coronally displaced and laterally. So apically displaced, when we will do, when there is a need for increase of attached gingiva. Coronally displaced, when we will do, when there is multiple recession. ஒரே ஒரு பல்லு இருக்குன்னா we can do a laterally displaced. நிறைய பல்லு இருக்குன்னா we will be doing a coronally. And when we will do apically displaced, when there is apically displaced to increase the width of the attached gingiva. சரியா? So this all displaced. And based on the management of the papilla, we will do conventional flap surgery. இன்னொன்னு papilla preservation. இது இந்த papilla preservationல ஒரு MCQ வர சான்ஸ் இருக்கு. என்னன்னா usually when there is a need for a placement of graft, a better type of surgery is papilla preservation. Okay? Papilla. இதுல இன்னொன்னு இருக்கு. நம்ம healing படிக்கும்போது what we will say? Primary healing and secondary healing. In papilla preservation flap with graft, there is a tertiary healing takes place. Usually in MCQ for PG they will write tertiary healing takes place in graft with papilla preservation technique. அதெல்லாம் யூசுவலா நம்ம பிரைமரி செகண்டரியில பிரைமரியில இன்சிஷன் சொல்லுவோம், செகண்டரியில ஓப்பன் wound சொல்லுவோம். அப்ப கிராஃப்ட் வந்து டெர்ஷரி மெட்டீரியல், அது எப்ப ஹீல் ஆகும்? டெர்ஷரி ஹீலிங். அண்டர்ஸ்டுட்? Is it clear this? Can I go to the next slide? So I already told you full thickness is mucoperiosteal, partial thickness is split thickness, otherwise mucosal. This is a full thickness flap. See there? Underlying bone is exposed. அதனால இது full thickness. இல்லனா என்ன சொல்லுவோம்? mucoperiosteal சொல்லுவோம். See this is a partial thickness. இங்க பாருங்க. Bone is not exposed fully. The periosteum is still attached. இந்த இதுல பாருங்க bone கம்ப்ளீட்டா உங்களுக்கு ஒயிட்டா தெரியும். ஆனா இதுல பாருங்க உங்களுக்கு தெரியாது. ஏனா the periosteum is still attached, blood is there, and then we call it as a split thickness, otherwise mucosal. Split thickness, mucosal, partial எல்லாமே ஒண்ணுதான். ஓகேவா? Based on the placement I told you non-displaced and displaced. Displaced தான் மூணா பிரிப்போம். One is apically, one is lateral, one is coronally. And non-displaced is until the flap is returned and sutured in the original position. That is non-displaced. And then this apically I have already told you. This is to increase the width of the attached gingiva. This is for multiple resection. This is for single resection. இங்க பாருங்க, it is returned to the original position. ஓகேவா? flap reflect பண்ணியாச்சு, granulation எடுத்தாச்சு and return to the original position. See this? Okay. See apically displaced. இங்க பாத்தீங்களா? இங்க இருக்க flap. இத வந்து apically displaced. Are you able to see that? So அப்ப பண்ணும்போது என்னாகும்? உங்களுக்கு width of the attached gingiva increase ஆகும். இங்க பாருங்க. இந்த area is exposed. இங்க பாருங்க. இது யூசுவலா இதோட டைப் பண்ணும்போது undisplaced ஆயிடும். ஆனா இத வந்து நாங்க bone graftக்கு மேல பண்ணி increasing the zone. புரியுதா? என்னமா? எந்த இடத்துல? நம்ம அட்டாச் gingiva எங்க இருந்து எடுப்போம்? ஃப்ரீ gingival groove ல இருந்து எடுப்போம். இங்க வந்து இந்த ஃப்ரீ gingivaவே இல்ல பார். போயிடுதுல? இதுதானே ஃப்ரீ gingiva. இப்போ இங்க இங்க இருந்து இருக்க வேண்டியது இந்த லெவல்ல வந்துருச்சு. சோ இங்க இருந்து வரும்போது உனக்கு இன்கிரீஸ் ஆயிடும்ல? இன்கிரீஸ் ஆயிடும் இல்லையா? Apically displaced, இங்க பாருங்க, apically displaced flap preserve the outer portion of the pocket wall and transform it into the attached gingiva. சரியா? Therefore, they eliminate the pocket and increases the width of the attached gingiva. Pocket eliminate ஆயிடுதாங்க. So attachment increase ஆயிடுது. Apically displaced flap preserves the outer portion of the pocket wall. Okay? அப்போ transform it into the attached gingiva. Therefore, they eliminate the pocket and increases the width of the attached gingiva. புரியுதா? coronally displaced. இங்க பாருங்க, these are all partial thickness, that is not full thickness. Okay, இது அப்படியே coronal they will take it. So this recession la inga in the coronal displace la usually they will do only there is a multiple recession. Sometimes they will do coronally எப்பன்னு கேட்டா இந்த இதை வந்து mucogingival சைடில் வரும்போது இங்கே ஃபுல் திக்னஸ் ரைஸ் பண்ணிட்டு இங்கே பார்ஷியல் பண்ணிட்டு புஷ் பண்ணும்போது ஆட்டோமேட்டிக்கலாக இந்த mucogingival ஜங்ஷனில் இட் வில் கெட் லூசன்ட், ஈஸியாக புல் பண்ணி மேலே வைக்க முடியும். ஆனால் இண்டிகேஷன் ஃபார் கொரோனலின்னு கேட்டால் when there is a multiple recession is better. Okay, and இன்னொன்று எப்போ பண்ணலான்னு கேட்டால் this coronally displaced flap with a graft. இப்போ பேலட்டிலேருந்து இங்கே கிராஃப்ட் எடுக்கிறீங்க, அந்த சமயங்களில் இதுக்கு மேலே இந்த கிராஃப்ட் வச்சுட்டு அதுக்கப்புறம் இதை எடுத்து இங்கே சூச்சர் போடுவாங்க. புரியுதா? laterally displaced, only single tooth is there, then you can go ahead with the laterally displaced. இங்கே இது பாருங்க, laterally displacedல this is a recipient area, ஓகேவா, or recipient area, adjacent tooth, this is an adjacent tooth, and non-donor tooth the next tooth. So where there is a R they have written is a recipient tooth, where you are going to get the thing, and the D is a donor tooth. So இந்த இதை வந்து இதை அப்படியே எடுத்து இதுக்கு மேலே வச்சு சூச்சர் பண்ணிப்பாங்க. அதனால தான் we call it as a laterally reposition. ஓகே, இங்கே பாருங்க, இதை அப்படியே எடுத்து இங்கே இப்படி பொசிஷன் பண்ணும்போது this raw area will have a secondary healing, this where you have incision this area will have a primary healing. Lateral reposition la da there are two type of healing takes place. Graft la there are three type of healing takes place. Lateral reposition la இந்த இடத்துல இருக்கிற இந்த recession இங்க இருக்க tissue தூக்கி அங்க மூடும்போது இங்க ஓபன் ஆயிடும். This will heal by means of secondary, this will heal by means of the primary. Are you clear now? Based on the management of a papilla, conventional flap and papilla preservation flap. Papilla preservation la usually ரெண்டு question வரும். When there is a spacing or diastema, what type of flap and keta, you should answer papilla preservation. Where there is a tertiary healing takes place, keta graft vekumbodhu. Which is the best method for best type of flap while you are doing putting a graft and ketalo? Papilla preservation. Papilla preservation mainly it covers the aesthetic need. Okay, ma? See, in conventional flap, the interdental papilla is split beneath the contact point of the two approximating. Correctly anga split ஆயிடும். Then you will do the reflection after doing surgery. Correctly enter பண்ணி பிரிச்சு then you are closing it up. Whereas in papilla preservation, incorporates the entire papilla in one flap by means of clavicular interdental incision to sever the connective tissue attachment and horizontal incision at the base of the papilla, leaving it connected to one flap. I don't think you have understood anything in that. You do understand two things. Here, the papilla is not severed. Number one thing, full papilla. Second thing, there are two type of incision you will do. One is clavicular interdental incision. Number two is horizontal incision. ரெண்டு type of incision. இங்கெல்லாம் just fitting தான். ஆனால் இங்கே வந்து clavicular interdental வரும். ரெண்டாவது horizontal at the base of the papilla வரும். So I show the picture. இங்க பாருங்க, conventional flap. இதுல பாத்தீங்களா கரெக்டா severing at the base of the papilla. தெரியுதா? Imaginary line போட்டுட்டு ரெண்டா பிரிச்சிரும். Okay, this is conventional flap. See this? Severing at the interdental area, பிரிச்சிட்டு after doing a surgery you will close it back. That is conventional. The interdental papilla is split beneath the contact point of the two adjacent teeth. Okay. Now, papilla preservation. I told you clavicular between the interdental area and horizontal also. இப்போ பாருங்க, circular நம்ம கொடுத்துட்டோமா, and interdental we are not going there at all. Okay வா? Labiala there is a circular incision. இங்க பாருங்க, இது circular incision. You see that interdental நம்ம ஒண்ணுமே பண்ணல. அச்சா, இங்க பாருங்க semilunar incision between the interdental area. பேலட்டில் பக்கல் இப்படியே தான் இருக்கு, ஞாபகம் வச்சுக்கோங்க. பக்கல் நம்ம ஒன்றும் பண்ணல, சர்க்குலராக தான் கொடுத்துருக்கோம். ஆனால் பேலட்டில் we are giving a semilunar clavicular. Okay, இப்போ இந்த I'll show it in the thing and then we will give a horizontal. ஓகேவா? இப்போ இது ரெண்டையும் நீங்க சர்ஜரியில பாருங்க. இங்க பாருங்க, they are giving only a circular. இப்போ நீங்க வந்து பேலட்டலா, இன்டர்டென்டலா, கிரவிகுலராவும் ஹாரிசான்டல் கொடுக்கும்போது அந்த பாப்பிலா லேபியலா இப்படி ரிஃப்ளெக்ட் ஆயிடும். So palatala you are doing, labia you have done only circular. Ana palatala you have given two incision, one is horizontal and interdental clavicular. So another full papilla comes out. Ipo palatal area parunga. Therida? புரியுதாமா? இந்த இங்க இருந்த இது வந்து அங்க லேபியலா போயிடுச்சு. தெரியுதா? palatal suture. ஏன்னா நம்ம பக்கல நம்ம ஒண்ணும் பண்ணல இல்லையா? Okay. So now we have understood. See what we have said, clavicular interdental to sever the connective tissue attachment and horizontal incision at the base of the papilla. Remember that and see the picture now you will understand. So இதுல வந்து சல்குலரா போட்டுட்டோம், இன்டர்டென்டலா இன்சிஷன் போட்டுட்டோம் அண்ட் பேஸ் ஆஃப் த பாப்பிலால இன்டர்டென்டலா கிரவிகுலரா இந்த இன்சிஷன் போட்டுட்டோம், பேஸ் ஆஃப் த பாப்பிலாவில் ஹாரிசான்டல் போட்டுட்டோம். அப்ப இந்த பாப்பிலா பேலட்டல் செல்ல சிவியர் ஆயிடும், அதை அப்படியே இந்த பக்கம் கொண்டாந்து சூச்சர் போடும். So your papilla is not hurted there at all. See, அந்த இன்டர்டென்டலா இருக்க வழியா அந்த பாப்பிலாவை நீங்க வெளியில கொண்டு வர முடியும். அதுக்கப்புறம் கிராஃப்லாம் வச்சுட்டு இந்த பாப்பிலாவை பேலட்டலுக்கு எடுத்துட்டு போய் the suture will be on the palatal area. இப்போ புரியுறதா உங்களுக்கு? இங்க பாருங்க, interdental there is an incision and base of the papilla போடுறதுனால அது ஈஸியா ரிஃப்ளெக்ட் ஆகி அந்த பக்கம் போய் suture போட்டுற முடியும். Now incisions, there are two type of incisions are there, horizontal and vertical. Horizontal incision என்னெல்லாம் horizontal incision வரும்? Internal bevel incision, clavicular, interdental. ஓகேவா? இது எல்லாமே horizontal. Internal bevel incision, when we will do internal bevel incision? When we are doing flap surgery. Gingivectomy, external bevel. Okay. Clavicular incision, இப்போ கூட நாம பார்த்தோம், interdental we are giving a clavicular, then interdental. All these things will come and horizontal நீங்க இந்த straight line யோசிக்க கூடாது. Wherever the blade moves in a horizontal way. One is internal bevel, where we do a modified Widman, we will do a internal bevel, clavicular incision and then interdental. Vertical is only oblique releasing incision. Oblique releasing incision. அது மட்டும் தான் vertical. வேற எதுவுமே vertical கிடையாது. இங்க பாருங்க, these are all horizontal incision. இல்லையா? இந்த planeல போறது. Horizontal incision are directed along the margin of the gingiva. You remember, horizontal incisions are directed along the margin of the gingiva in a mesial and distal direction. Internal bevel incision, it is always the first incision. And reverse bevel, your other name for internal bevel is reverse bevel incision. It is a first incision. 11 and 15 surgical scalpel is used. Starts distant from the gingival margin aiming at the bony crest. இங்க பாத்தியா? இந்த incision ஓட aim வந்து towards the bony crest. அதனால தான் we are doing this at modified Widman flap. They can ask you first incision போட்டுருவாங்க, கீழே clavicular எல்லாமே போடுவாங்க. அப்ப you should think internal bevel incision is the first incision. 15 or 11 blade can be used. It is directed towards the alveolar crest. And reverse bevel. So you always remember, the bevel in வரும்போதே internal or external வரும். External for gingivectomy, internal for flap surgery. And different type of flap surgery இருக்கு. அப்ப internal bevel எதுக்கு யூஸ் பண்ணுவீங்கன்னு கேட்டா, modified Widman flap க்கு மட்டும் தான் we will use reverse internal bevel incision. Widman flap is more or less like a conventional flap. Modified Widman we will use only at the posterior area. என்ன ப்ராப்ளம்னா, அதுல reverse bevel, internal bevel யூஸ் பண்றதுனால what will happen, some amount of tissue is removed. After the healing there is a wide chance for recession. So modified Widman cannot be used in the anteriors, they will use only in the posteriors. ஓகேவா? see this, இங்க பாருங்க தெரியுதா? certain amount of tissue is removed along with the connective tissue and the pocket epithelium. அப்ப என்ன ஆகும்? ஏற்கனவே ஹீலிங் ஆன பிற்பாடு ஷிங்கேஜ் இருக்கும். இதுல நீங்க இவ்வளவு டிஷ்யூ வேற ரிமூவ் பண்றீங்க. don't you think you will get the recession? yes or no? சரியா? இங்க பாருங்க, இந்த பாருங்க அப்படியே ரிமூவ் ஆயிடும். இதுல என்னன்னா இந்த இன்சிஷன் போட்டு எடுக்கும் போது some amount of connective tissue, diseased tissue plus some amount of tissue will be removed. அதனால தான் we are not using in the anteriors, mostly we will use in the posteriors. ஓகேவா? இதுல போட்டிருக்கான் பாரு, removes pocket lining and conserves uninvolved outer surface of the gingiva, produces a sharp thin flap margin. இதுல பெரிய அட்வான்டேஜ் என்னன்னா தின்னிங் வந்து ஆட்டோமேட்டிக்கலா இன்சிஷன்லயே வந்துரும். அதுக்கு நீங்க இன்னொரு ஸ்டெப் யூஸ் பண்ண வேண்டாம். ஓகேவா? clavicular incision. Clavicular incision is otherwise known as second incision or sulcular incision. Second incision or sulcular incision made from the base of the pocket to the crest of the bone. See there? Base of the pocket and the crest of the bone. See the base of the pocket இல்லையா? Base of the pocket and the crest of the bone, and forms a V-shaped wedge tissue together with the first incision ending near the crest of the bone. So, clavicular incision is second incision. இன்னொரு பேரு sulcular incision. இதுல என்ன ஆகும்? Base of the pocket ல இருந்து crest of the bone வரை tissue can be removed. So, என்ன ஆகும்? The V-shaped tissue. இங்க பாரு, V-shaped. V வருதா? இங்க pocket lining, diseased tissue plus pocket, depth of the pocket, அப்படியே இந்த V-shaped அப்படியே remove ஆயிடும். ஓகேவா? The wedge of tissue contains inflamed granulation tissue area that constitutes lateral wall of the pocket, number 1, as well as junction epithelium and connective tissue fibers. அதனால உங்களுக்கு V shapeல வந்துரும். அதனால தான் internal bevel, clavicular எல்லாம் வந்து ஒண்ணா சேர்ந்து யூஸ் பண்ணும்போது இந்த V shapeல வந்துறதுனால some amount of healthy gingiva, அந்த margin gingivaவும் போயிடுறதுனால உனக்கு recession ஜாஸ்தியா இருக்கும். அதனால modified Widman posteriorல பண்ணுங்க, Widman anteriorல பண்ணுங்கன்னு சொல்றாங்க. புரியுதா? Interdental. This is the third incision. So first incision is the internal bevel, second is clavicular or sulcular, third is interdental incision. இதுல வந்து Orban knife is used. Incision made facially and lingually and interdentally connecting the two segments separates the collar of the gingiva around the tooth. Okay, இதுல third incision உங்களுக்கு நல்லாவே புரியும். கரெக்ட்டா? Interdental. And these three incisions allow the removal of the gingiva around the tooth. A curette is used for this purpose. If only horizontal incisions are given and no vertical incisions are made, the flap is called an envelope flap. Envelope அப்படியே ஓபன் பண்ணி க்ளோஸ் பண்றது. There is no thing. இதுல இன்னொன்னு என்னன்னா Widmanல most of them they will use even the vertical incision. அந்த type of flapல. இந்த envelope flap பண்றது just ஓபன் பண்ணி க்ளோஸ் பண்ற மாதிரி. அங்க உனக்கு வந்து vertical releasing incision is not there. Understood? No. Vertical oblique releasing incision. See the vertical incision. Where there is a vertical incision, இங்க தெரியுதா? தெரியுதா? This is only vertical releasing incision. அது பாருங்க படத்துல இங்க போட்டுருக்கேன் பாரு. ஓகேவா? The vertical incision can be used on one or both the ends of the is the horizontal incision. Vertical releasing incision ஒரு சைடுலயும் யூஸ் பண்ணலாம் இல்ல both சைடுலயும் யூஸ் பண்ணலாம். Must extend beyond the mucogingival junction. அப்போ யோசிச்சு பாருங்க எங்க யூஸ் பண்ணலாம்? coronary repositionல யூஸ் பண்ண முடியுமா? clavicular போட்டுட்டு மேல இழுக்க முடியும் இல்லையா? And the flap should be as wide apically than coronary to maintain the adequate. Only thing, the base of the flap should be wider than the coronal. அப்பதான் உனக்கு blood circulation maintain ஆகும். இங்க பாருங்க. This is wrong. ஓகேவா? You need a blood supply here. ஆனா இந்த சைடுல இப்படி போடும்போது wrong ஆயிடும். அதனால தான் flap இந்த horizontal vertical releasing கொடுக்கும்போது இப்படி கொடுக்கணும். ஓகே? இப்படி கொடுக்க கூடாது. இப்படி கொடுத்தீங்கன்னா blood circulation போயிடும். வைடரா கொடுக்கணும். பேஸ் மஸ்ட் பி வைடர். இங்க பாருங்க, பேஸ் வைடரா இருக்கணும். done this, isn't it? You are able to understand? இதை வந்து பேஸ் எப்பவுமே வைடா இருக்கிற மாதிரி பார்த்துக்கணும். இப்படி கொடுக்க கூடாது. ஓகேவா? Incorrect location for vertical. Correct location for vertical. Incorrect. Correct. Okay, this incision should be like this, not correctly at the center. இப்படி கொடுக்க கூடாது. See this? Incorrect location for vertical incision. It should not be interdental. Why they are saying incorrect? This is, it will sever the interdental area, isn't it? So அதனால நீங்க கொஞ்சம் தள்ளி கொடுக்கும்போது there will be a correct location for vertical incision. Elevation of the flap, the periosteal elevator, Molt 9. I told you, no, periosteal elevator different type. So sharp dissection is necessary to reflect a partial thickness flap. Surgery, for a partial thickness you can use 11 or 15. Suturing techniques. These are all a different type of suture material. Non-resorbable, absorbable and synthetic. I mean silk braided is always non-resorbable. Even black silk is non-resorbable. Nylon, EPTDFE and polyester, these are all non-resorbable. Non-resorbable in the sense, after suturing you have to ask the patient to come after 7 days for suture removal. And resorbable, it will resorb by itself, and usually surgical gut. It is only a monofilament, thin filament. Okay, and plain gut is there and chromic gut is there. Chromic gut within 45 to 60 days it will get resorbed, whereas plain gut 30 days. And then synthetic, polyglycolic, this thing, and then polyglyconate. All these things are synthetic. Usually in periodontal thing we are using non-resorbable. And they are using any plastic surgery with the thin periosteal flap surgery, they will use a absorbable one. And these are all different materials. And needle curvature. See this? Circle, half circle, 1/4, 5/8, straight. These are all different. This is only needle point type. This is actually, they will, for you, they will give more important for reverse cutting edge. Usually needle with a reverse cutting edge we are using. Suturing instrument, corn suture pliers, as and tissue forceps, and this I already told you, when we are doing a plastic surgery with the thin flap you can use Castro Visual needle holder and all these scissors. Placement of sutures I have already said, all these things is over. We are going back up, correct Dhanay? Is all I finished now? What, repeating it down? Modified and goals of modified Widman. Calculus removal, granulation tissue removal, reattachment, minimal recession and flap closure. So when and all you will do modified Widman? See, pocket where the bases are located coronal to the mucogingival junction and little or no thickening of the marginal bone, shallow moderately deep pockets and aesthetic importance. So aesthetic importance is this modified Widman, aesthetic importance especially in the anterior region of the patients with high smile line. Advantages, location of internal bevel, procedures. Here you need internal bevel, reflection of the flap, sulcular, interdental. All three type of incision will be there in the modified Widman. So 0.5 to 2 mm from the mucogingival junction this incision should be. Okay. Flap curettage and modified Widman. This is undisplaced flap. Usually it is also referred as internal bevel gingivectomy, undisplaced. The other name for this is internal bevel gingivectomy. These are the procedures how we are doing a flap surgery. Apically displaced, already I told you, it helps in increasing the width of the attached gingiva. And mainly the flap is to improve the accessibility for instrumentation. This one. Distal molar surgery, I told you we will do it in the molar. See, the typical incision designed for a surgical procedure distal to the maxillary second molar. Usually, when you are doing a flap surgery, we will ask the patient to remove the 8 because it does not have any function in the oral cavity. Sometimes the patient does not want, we will retain it, but on the distal side, we will do either curettage, otherwise we will do a extension like this. Distal wedge incision to expose the bony defects at the root surface. Osseous surgery and root planing are followed by suturing flaps so that soft tissue is in close proximity to the distal bone with post-surgical reduction of the pocket depth. Usually what happens, like a second molar, otherwise a third molar, if that area is free, what happens? After doing a surgery, we will give the suture till the mesial side of the distal side, we won't be giving it. That time what will happen? There will be a recurrence of the pocket. To avoid that, we will do a distal wedge surgery. See this, how we are taking it. Understood? According to the space. Healing. The blood clot is formed between the flap, the tooth and the bone. 1 to 3 days later, epithelial cells migrate over the border of the flap and space between the flap and the bone is thin and less inflammatory response. So, first 3 days there will be a less inflammatory because the recruitment of the PMN is not yet completed. Shariya? And first week later, the epithelial attachment is established. I have already told you 7 to 14 days for epithelial formation. So, the first week later epithelial attachment is established. Second week, the collagen fibers begin to appear. 1 month later, fully epithelialized gingival sulcus is established. So, when the collagen fibers begins to appear, second week. Why we are saying in the second week collagen fibers, I already told you, this connective tissue formation will take place between 14 days to 21 days. So, naturally the collagen comes on the second week. Okay. You are able to understand? First week is epithelial attachment, second week is collagen. Then furcation. Inflammatory periodontal disease affects the bifurcation or trifurcation of the multirooted teeth. The furcation is an area of complex anatomic morphology that may be difficult. Why we are saying this is furcation area we are giving importance? Because the instrumentation is difficult. At the same time, accumulation of the plaque on the calculus is more. Self-cleansing also is not possible even if the furcation is open. Okay, ma? So, mainly just getting the instrumentation there is not so easy. So, primarily bacterial plaque accumulation, local anatomic factors like root trunk length and then morphology, cemento-enamel projections, always. What is cemento-enamel projection? It is the enamel projection from the CE junction. Sometimes it will come little to the root trunk, sometimes it will extend the full root trunk, sometimes it will enter the furcation area. Okay? And dental caries and the pulpal teeth. So, all pulpal teeth, all these things are etiology factor where the furcation is involved. See, inga parunga. Therida? Maximum we are getting a disease here only because plaque bacteria easily get accumulated there. And cleansing is not so easy. Even instrumentation is not easy. For that only furcation should be given more important when you are treating a dental disease. Is it boring? You tell me, otherwise we are not able to understand also, you tell me. Okay, ma'am? See this, furcation entrance. This is furcation entrance. This is the fornix. Apex of this entrance of the furcation. This we call it as a root trunk. Okay, ma'am? The entrance is the transitional area between the undivided and divided part of the root. Usually they are asking this in the MCQ. Roof of the furcation. Roof of the furcation is, for example, most of the people they are writing it is a transitional area between the undivided and divided part. This is undivided and this is a divided. This is entrance. Whereas the roof of the furcation is fornix. That they are asking in the orals. I mean MCQ entrance. So where you will measure the vertical bone loss? It is from roof of the furcation. That means from fornix. Don't forget that they are asking. இங்க பாருங்க furcation probing we will do by means of neighbors probe. இங்க பாருங்க mandibular molars, there's a buccal furcation. They place the probe between the two buccal roots from buccal aspect. Two lingual root. Furcation radiography should include both periapical and bite wing. You remember both are important furcation ke. Bite wing plus periapical. Location of the interdental bone and the bone level within the root complex should be examined. இதுதான் நீங்க முக்கியமா எக்ஸாமின் பண்ணணும். இது furcation entrance, இது fornix, இந்த இடத்துல தான் you will get the disease. Differential diagnosis may be usually the furcation only because of the pulpal petosis and sometimes causes lesion in the periodontal tissues of the furcation and trauma from occlusion. What will you do treatment? இதுல நீங்க ஞாபகம் வச்சுக்க வேண்டியது furcation grade 1, grade 2, grade 3 like that. Grade 1 you just do simple scaling, SRP, this thing. Grade 2 flap surgery if there is any graft. Grade 3 tunneling. Grade 4 depends upon the severity. Usually in MCQ they will ask in furcation கேட்டா 3-4 விஷயங்கள் கேட்பாங்க. Furcation fornix பத்தி கேட்பாங்க. Then which will have a poor prognosis when you treat the furcation கேட்பாங்க. And then they will ask about this neighbors probe. Okay, and then they'll ask about grade 3 furcation. The usual questions in perio, furcation, MDS entrance, these 4 questions they will ask. Non-surgical root preparation, see, most effective in grade 1 and shallow grade 2. So, grade 1 la enna treatment is scaling and root planing. Okay, antimicrobial, all those things, soap and debridement. Grade 2 osseous surgery. Grade 1 scaling and root planing. ஏன் grade 2 osseous surgery? ஏன்னா cul-de-sac ஒரு பக்கம் bone loss இருக்கும், ஒரு பக்கம் bone loss இருக்காது. So you better you do a osseous surgery. What type of osseous surgery? Osteoplasty and osteectomy, both should be done. இப்போ இது பண்ணனும்னா என்ன பண்ணனும்? You have to raise the flap, isn't it? So grade 1 na it is only scaling and root planing. அதே மாதிரி shallow grade 2 அப்படினாலும் வெறும் scaling root planing. வெறும் grade 2 ன்னு கொடுத்தாங்கன்னா you should write about osseous surgery. And grade 2 and grade 3 root resection. And இதுல நீங்க முக்கியமா ஞாபகம் வச்சுக்க வேண்டியது grade 3 in mandibular ன்னு கேட்டாங்கன்னா you should go ahead with tunneling. Grade 3 tunneling. ஏன்னா cul-de-sac இல்ல, ரெண்டு பக்கமே அந்த இதுல ரெண்டு பக்கமே there is hole. You can put the instrument self cleansing unit after brush வச்சு clean பண்ண முடியும். அப்ப you can do tunneling. And in case இன்னொன்னு பாரு, இந்த இத root resection இந்த படத்தையும் பாரு, என்ன தெரியுது? One root is removed. இல்ல நீ மோலார்ல வந்து root resection நான் சொல்லுவேன். Won't you say hemisection? Root section should be used only for the molar and mainly upper maxillary molar, mainly buccal root will be removed, not the mesial or palatal. So the roots resection வார்த்தையை you can use only for the maxillary molar, not for the mandibular. Mandibular நீ யூஸ் பண்ணனும்னா எப்ப வந்து mandibularல grade 3 furcation இருந்துச்சுனா you can do tunneling. எப்ப வந்து hemisection பண்ணுவீங்க அப்படினா if the root, one of the root is involved with the periapical pathology. புரியுதா? root resection only one root is involved. இப்ப இந்த ரூட்ல பயங்கர bone loss இருக்கு, periapical pathology இருக்கு, you remove this root and with these two root you will have a better stability. And maxillary, so please don't use the word root resection for mandibular molars, okay ma? And see this sequence of treatment for root resection. எப்படி root resection பண்ணுவோம்? endodontic treatment பண்ணாம பண்ணவே முடியாது. You should do endodontic treatment. இப்போ வந்து molarல grade 3 furcation இருக்கு upperல. Can you do a tunneling? You cannot do tunneling. ஏன்னா palatal root வந்து இது பண்ணும். அப்போ எந்த endodontic treatment முடிச்சிட்டு எதுல வந்து most of bone loss இருக்கோ அந்த particular root remove பண்ணணும். அதுல priority எதுக்கு கொடுக்கணும்? distal rootக்கு கொடுக்கணும். palatal கொடுக்க கூடாது because it is the longest, thickest and it is important for stability. mesialக்கு கொடுக்க கூடாது ஏன் கேட்டா பக்கத்துல premolar இருக்கு, they will have a thin bone separation between the molar and the premolar. So the better root is distobuccal, and you can use the word root resection only for the maxillary molar, not for the mandibular. Understood? இங்க பாருங்க, factors to be considered, all these things. This is actually they don't want to ask you. And hemisection. இப்போ hemisection you can say for lower mandibular molar. Other word for hemisection is bicuspidization. Why do you say bicuspidization? The cusp is divided into, both the cusp will be there in the molar, the mesiobuccal and distobuccal, they are making a vertical cut there. See, you remember mandibular molars, where you will do hemisection is grade 3 furcation, need widely separated roots, soft tissue positioned below the pulp chamber. இப்போ வந்து grade 3 சாதாரணமா furcationக்கு நம்ம யூஸ் tunneling வந்து பண்ணுவோம். அதுல maxillary molarல tunneling பண்ண முடியாது. endodontica treat பண்ணிட்டு எந்த particular rootல bone loss இருக்கோ அதை remove பண்ணுவோம். அப்படி கொடுக்கும்போது distobuccalக்கு we will give more important. அதே lowerல வரும்போது in case one particular root alone is involved with more of bone loss and periapical pathology is there, we can do bicuspidization. The other name for this is hemisection. Are you clear now? Can you go to the next slide? Root separation. Root separation involves the sectioning of the root complex and maintenance of all roots. இரு அதுக்குதான் திருப்பி போறேன். அங்க bicuspidization நீ ரிமூவ் கட் பண்ற. hemisection, the tooth is section twice. hemisection, இந்த பக்கம் ஒரு பல்லு அந்த பக்கம் ஆயிடும். ஓகேவா? இதுல என்ன பண்ணுவோம்? you will make இந்த molar ரெண்டா பண்ணும்போது premolar மாதிரி ஆயிடாது. அதுக்கு மேல we will give a crown. அது ஒண்ணு. இன்னொன்னு என்ன பண்ணுவோம்? the half of the root ரொம்ப மோசமா இருக்குன்னு வெச்சுக்கோ, with the crown ஓட ரிமூவ் பண்ணிடுவோம். இத abutment வச்சு we can put a bridge work. புரியுதா? அதுதான் hemisection or bicuspidization. ஆனா root resectionல இந்த ரெண்டு ரூட்டுமே தனியாக்கிடுவோம். இங்க பாரு, root separation involves sectioning of the root complex and maintenance of all the root. It will maintenance of all the roots. Understood? இங்க பாருங்க, தனித்தனியா கவுன் மாதிரி இது ரூட் இதுல இது ஒரு தனி ரூட். ஒரு இங்க பாருங்க, இது ரூட் ரிசெக்ஷன், ரூட் செப்பரேஷன் இன்வால்வ் செக்ஷன் ஆஃப் தி ரூட் காம்ப்ளெக்ஸ் வரும்போது இது ஒரு தனி டூத் ஆயிடும், இது ஒரு தனி டூத் ஆயிடும். shall I repeat it again? புரியுதாப்பா? இதுல வந்து bicuspidization-ல இங்க பாரு, ஒன்னு அப்படியே ரிமூவ் பண்ணிடுவோம். ஹெமிசெக்ஷன்ல இதா இது இப்போ வந்து இப்படிதான் இருக்குன்னு வச்சுக்கோ, இதை வச்சு நீ என்ன பண்ண போற? பண்ண முடியாது. இதுல வந்து RCT பண்ணிட்டு இதை கட் பண்ணி இந்த ரூட்டை ரிமூவ் பண்ணிட்டு இதை we can keep it as an abutment, then you prepare a bridge. This is hemisection. Whereas இதுல ரெண்டு ரூட்டை கட் பண்ணி இது தனியா ஒரு ப்ரீமோலார்மா இருக்கும், இது தனியா ஒரு ப்ரீமோலார்மா இருக்கும், இன்டர்டென்டலா கிளியரன்ஸ் இருக்கும். புரியுதா? இதுதான் ரூட் செப்பரேஷன். The full complex is sectioned into two and maintenance of all the roots will be there. ஆனா hemisection bicuspidization one root will be removed. புரிஞ்சுச்சா? அத வந்து அந்த ஒன் ரூட்டோட இருக்க அந்த டூத் ஒரு வந்து அபட்மெண்டா யூஸ் பண்ணி நம்ம பிரிட்ஜ் பண்ணுவோம். See this. tunnel preparation, grade 3 furcation, Fermit's block removal. ஏன் tunnel preparation இதில் பண்ணுறோம் அப்படின்னா, we will use, see இதுவங்க tunnel மாதிரி prepare பண்ணிட்டு, இதை self cleansing வைப்போம். Unit after brush போட்டு they will clean it up. Regeneration of the furcation. With the GTR, இது வந்து graft இருக்குல்ல, இதை நல்லா clear பண்ணிட்டு, இங்க graft வச்சுட்டு, அதுக்கு மேலே GTR வச்சு we will close it out. Okay? The guided tissue region predictable outcome of GTR therapy was demonstrated only in grade 2 furcation involving mandibular molars. Less favorable results have been reported in other types. So, GTR regeneration of furcation defects mainly you can do it in grade 1, 2, 3 in potangana, only grade 2. Okay, ma? Grade 2. ஏன்னா cul-de-sac அந்த பக்கம் உனக்கு வந்து bone support இருக்கும், இங்க மட்டும் தான் இருக்காது. See furcation defects, most predictable furcation and least predictable. Most predictable mandibular or maxillary, buccal maxillary class 2, mesial or distal maxillary class 2. Least predictable is 3 and 4. So predictable is 2 mainly. Least predictable is 3 and 4. Osseous grafting, autogenous, allograft, alloplast and bioglass. These are all figures where they are putting the graft. See the graft. Then approximating, they are suturing it out. Okay. Extraction, attachment loss is so extensive that no root can be maintained. Then you go ahead with the removal. If tooth or gingival anatomy will not allow proper plaque control, the anatomy is not allowing the proper control, then you remove the tooth. And then for endodontic or restorative reasons, an osseointegrate implant substitute. All these conditions will go for a extraction. So, depends upon the attachment loss. If the tooth is not endodontically treated, cannot be treated periodontally, then you go ahead. And the anatomy of the gingiva or this thing is not allowing to maintain the proper plaque control, remove it out. Prognosis. Pulpoperio problem, pathways of communication between the pulp and the periodontium, pathways of developmental origin, pathways of pathological origin. Actually, they can ask you one question in this is pulpoperio problem where you will be more of prognosis. If it is endodontic in reason, more prognosis will be there. That is why primary endodontic will show more prognosis. When pulpoperio problem comes, give more important first for pulpal endodontic treatment, then go ahead perio. Because even the accessory canals can release by the means of accessory canals also there is a release of toxins. So you first close the endodontic treatment, then go ahead with the perio, you will have a better prognosis. Pathways of iatrogenic origin, exposure of dentinal tubules following root planing, accidental lateral perforation during endodontic procedure, root fracture due to endodontic. Types of endoperio, primary endo with secondary perio, primary perio with secondary endo and true combined lesions. These are all different types. Splints. It provides this redirection the forces. Principle of thing you know mainly, here you give importance for this line first. Coronoplasty may be performed to relieve the traumatic occlusion. Before doing a splinting, you have to do coronoplasty. This they are asking in entrance. Dental implants, it is a biological or alloplastic biomaterial inserted into the soft and hard tissue of the mouth for functional and cosmetic purpose. The implant is mainly for functional or cosmetic purposes. Okay. And osteointegration is a direct structural and functional connection between ordered living bone and the surface of the load carrying implant. That is why the type of healing between the implant and the bone we say osteointegration. This osteointegration will give structural and functional connection. As because it is giving a structural and functional connection, it will be used either for functional or cosmetic. If you integrate pani paranga, you will remember. Understood? And then soft tissue interface of the implant consists of mucosal tissues around or intraosseous implants. So what type of healing take place? Fibroosseous integration. Okay, ma. These are the different type of implants: endosteal, subperiosteal, transosteal, submucosal, endodontic. And based on the surface, titanium plasma sprayed, but this is supposed to be the better one. Surgical procedures involves one stage endosseous implant surgery, in 2-stage endosseous implant surgery. Healing involves 2 phases: osseous healing and late stage. You remember, healing in implant involved 2 phases. This they are asking in MCQ. Osseous healing is a early phase, late phase. 2 stage irukku. அதே மாதிரி pathological alterations வரும்போது peri-implant mucositis and peri-implantitis. Then periodontal pharmacology. Here you are supposed to give importance for chlorhexidine. It is available as 0.12 products. PerioGard. Here what type of question comes is, they will put PerioGard, they will put the percentages. You should write PerioGard is available in 0.12. Definitely they are asking in MDS entrance, PerioGard. And one more thing is Peridex. This oral cleanse and Prosol, very rarely they are asking. They are giving importance for Peridex and PerioGard. And this is nothing but, 5 minutes. Is nothing but chlorhexidine 0.12 products. Okay, ma? Mechanism of action. This is broad spectrum bactericidal agent, high substantivity, reduced adherence. See this, please remember, this chlorhexidine is more important for reducing the adherence capacity of P. gingivalis. So mainly in chronic periodontitis, why we are giving chlorhexidine is because it not only it is a bactericidal, it avoids adherence of P. gingivalis. Understood? And they are asking this in MCQ. I forgot this. It ruptures the bacterial cell membrane and releases cytoplasm contents. Because all the mouthwashes not having this type, the main mechanism action is it ruptures the cell membrane. Once the cell membrane gets ruptured, what happens? Automatically the cytoplasmic contents comes out. What happens once the cytoplasmic cell content comes out? Cell death occurs. That's the mechanism. Uses full mouth disinfection, all other things. Okay. Periochip. This is what is this periochip? Local drug delivery la chlorhexidine. Okay, ma? Periochip they can ask you in this orals. And mechanism action, already I told you it's a bactericidal action. Indication, adjunctive therapy to debridement, where maintenance is preferred choice for care. Surgical care is contraindicated. Recommended dosage. See how they are keeping it. In the question comes on periochip is 3 questions. One is mechanism of action, what it is, which microorganisms get sensitive to this periochip. In the 3 questions, usually MDS entrance la kepanga. Adverse reactions, mild, moderate swelling, and usually you know this chlorhexidine gives discoloration, isn't it? Staining. Clinical efficacy is good here. Understood? Till now is it okay? You have tea and come for a question discussion.